Top 1. The Human Combustion Anomaly. In 1979, emergency responders entered a small apartment in Florida after a neighbor reported a strange odor and smoke residue seeping from beneath a door. Inside, the room showed limited structural damage. A chair had partially burned. The ceiling above it was stained with soot extending roughly 3 feet upward. Yet at the center of the scene lay what investigators described as a severe localized incineration. The torso of the occupant had been reduced to ash and fragmented bone. Lower legs, still clad in slippers, remained largely intact. Nearby newspapers were only lightly scorched. There was no evidence of a conventional accelerant. The pattern did not resemble a typical residential fire. Cases classified under the label spontaneous human combustion have appeared sporadically in forensic literature for more than a century. Most involve elderly individuals found indoors, with damage concentrated around the body and minimal spread to surrounding objects. In several instances, fatty tissue appears to have sustained prolonged burning, while nearby materials remain relatively untouched. The temperature required to reduce bone to brittle fragments can exceed 1,600 degrees Fahrenheit in controlled cremation settings. Yet in many reported scenes, the damage radius is limited to a few feet. Modern forensic science proposes an explanation known as the wick effect. In this model, an external ignition source, such as a dropped cigarette, initiates smoldering in clothing. Human body fat, once liquefied by heat, can act as a fuel source absorbed into fabric, much like melted wax sustaining a candle flame. The fire may burn slowly for hours, producing intense localized heat without erupting into a spreading blaze. This theory accounts for several observed features, including concentrated destruction of soft tissue and limited damage to surroundings. However, not all details align neatly in every case. Some reports describe insufficient evidence of a clear ignition source. Others note rapid combustion inconsistent with slow smoldering. Toxicology screens occasionally reveal alcohol or sedatives, which could impair awareness and escape, but do not explain ignition. Environmental variables such as airflow, room insulation, and body position complicate reconstruction. Forensic teams typically classify these incidents as accidental deaths with unusual burn patterns rather than unexplained phenomena. Importantly, there is no verified case in which a body ignited without any external spark. Yet the visual impact of these scenes, a body largely consumed while furniture remains mostly intact, continues to challenge intuitive understanding of fire behavior. The energy released appears disproportionate to visible environmental damage. From a biological perspective, the human body is not inherently combustible. It consists largely of water, approximately 60% by mass in adults. Sustained burning requires both heat and fuel concentration. The wick effect provides a plausible mechanism in many scenarios, but it relies on specific conditions aligning precisely. Even then, the process is slow, often producing limited flame, but significant thermal concentration. The anomaly lies less in violation of physics and more in the stark contrast between expectation and outcome. Most people assume that if a body burns extensively, the entire room would be destroyed. These cases demonstrate that under certain conditions, combustion can remain localized and deceptively contained. If the wick effect explains most instances, it highlights how organic tissue and fat distribution can transform the body itself into a sustained fuel source under rare circumstances. If some elements remain unresolved, they underscore how complex fire dynamics can be within enclosed environments. In either case, the phenomenon exposes a boundary between what seems biologically impossible and what may be physically plausible under specific constraints. When forensic evidence produces scenes that defy instinctive logic, the discomfort lingers. And when biology intersects with physics in ways that appear extraordinary, it forces a reconsideration of how easily perception can mistake rarity for impossibility. Top 2. The congenital pain void. In 2004, physicians at a regional hospital in Lahore documented a case that challenged one of the most fundamental assumptions in human biology. An 8-year-old boy was brought in after leaping from a rooftop approximately 12 feet high during what witnesses described as a street performance. He stood up immediately, no screaming, no tears. X-rays later revealed a fractured tibia and multiple hairline cracks along his left foot. The medical chart noted something more disturbing than the injuries themselves. The child reported no pain, not reduced pain, none at all. Initial evaluations ruled out shock. His pulse and blood pressure were stable. Neurological exams showed intact motor control and normal tactile sensation. He could feel pressure, temperature differences, even light touch. But when physicians applied a calibrated pinprick stimulus that would normally trigger instant withdrawal, he watched the needle enter his skin with quiet curiosity. There was no reflexive jerk, no change in facial expression. The body had registered contact. It had not registered threat. Something in the alarm system was silent. Pain perception depends on specialized nerve endings called nociceptors. These receptors detect extreme heat above roughly 113 degrees Fahrenheit, mechanical force strong enough to damage tissue, or chemical signals released during inflammation. Once activated, electrical impulses travel through peripheral nerves into the spinal cord and ascend toward the thalamus and cortex, where the sensation becomes conscious suffering. This chain reaction is fast, automatic, and deeply embedded in evolutionary survival. Remove it, and the organism loses its earliest warning mechanism. Genetic testing in similar documented cases has identified mutations in the SCN9A gene, responsible for producing the Nav1.7 sodium channel. This microscopic channel acts like a gatekeeper for electrical signaling in pain-sensing neurons. When functioning normally, it amplifies danger signals, so they reach the brain with urgency. When disabled by mutation, the signal fades before it can ignite awareness. The injury still occurs. The tissue still tears, but the message never arrives in full force. The consequences are cumulative. Children with congenital insensitivity to pain often present with unexplained scars, untreated fractures, joint deformities, and repeated infections. Without discomfort to limit behavior, they chew their tongues while teething, grind down teeth to the gum line, or continue running on sprained ankles. Some forms of the condition also impair sweating, disrupting temperature regulation, and increasing the risk of overheating. In clinical records, the most dangerous complication is not trauma itself, but delay. A broken bone ignored for days can heal incorrectly. An unnoticed wound can become septic. The absence of pain becomes a quiet architect of damage. Medical teams approach these cases with caution. There is no therapy that restores nociception. Management focuses on surveillance rather than cure. Families are trained to inspect limbs daily, to monitor body temperature, to prevent high-risk activities. In some regions, documentation is anonymized to protect children from exploitation or disbelief. The disorder is rare, but its existence is undisputed within neurology and genetics. Yet the deeper question lingers beyond the gene mutation. Pain is considered one of the most primitive and universal human experiences. It shapes learning, memory, fear, and social behavior. It instructs restraint. If a single molecular alteration can erase this sensation while leaving cognition and mobility largely intact, then pain is not as structurally inseparable from consciousness as once assumed. It is modular, switchable, and if one core survival system can be silenced so completely, what does that imply about other latent systems embedded within the nervous system? Systems that may activate or deactivate under conditions modern medicine has not yet mapped? Top 3. The fatal sleeplessness syndrome. In 1986, a 53-year-old man in northern Italy walked into a sleep clinic with a complaint that seemed ordinary at first. He had not slept properly in weeks. Sedatives did nothing. Alcohol did nothing. By the third month, the situation was no longer insomnia in the conventional sense. It was neurological collapse in slow motion. He could lie down. He could close his eyes. But his brain refused to enter sustained sleep. Polysomnography recordings showed fragmented electrical patterns, brief seconds of shallow drift, then abrupt returns to wakefulness. It was as if the machinery responsible for shutting the mind down had been dismantled piece by piece. Within 6 months, the symptoms escalated. His heart rate remained elevated even at rest. Blood pressure fluctuated unpredictably. He began to sweat excessively, then stopped regulating temperature normally. Hallucinations crept in at the edges of vision. Memory faltered. Muscle coordination deteriorated. By the 9th month, he had lost significant body weight despite adequate caloric intake. The body was burning through energy reserves without the nightly repair cycle that normally restores metabolic balance. Physicians recognized the pattern. His family history confirmed it. Several relatives across generations had died after similar cascades of sleepless decline. The diagnosis was fatal familial insomnia, a rare inherited prion disease. Unlike bacterial or viral infections, prion disorders are caused by misfolded proteins that trigger a chain reaction of structural corruption in neighboring proteins. In this condition, the thalamus, a deep brain structure critical for regulating sleep cycles and relaying sensory information, gradually degenerates. Imaging studies in documented cases show significant atrophy in thalamic nuclei responsible for coordinating the transition between wakefulness and restorative slow-wave sleep. The damage is microscopic at first, invisible to casual observation, but relentless in progression. Sleep is not a passive state. It is an orchestrated neurological event involving synchronized brain waves, hormone release, immune recalibration, and cellular repair. During deep sleep, growth hormone surges, toxins are cleared from neural tissue through lymphatic flow, memory consolidates, emotional regulation resets. Remove this process entirely, and the organism does not simply feel tired. It destabilizes system by system. In fatal familial insomnia, the brain remains locked in a hyper-aroused state even when the body begs for shutdown. There is no curative treatment. Experimental sedatives can induce unconsciousness, but they do not restore true physiological sleep architecture. EEG tracings rarely show the sustained slow delta waves required for recovery. As months pass, patients enter a state of profound cognitive impairment. Autonomic dysfunction intensifies. Ultimately, multi-system failure occurs, often within 12 to 18 months from onset. The condition is rare, affecting only dozens of known families worldwide, but its clinical reality is firmly established in neurology. Research laboratories have mapped the responsible mutation in the PRNP gene. Genetic testing can confirm risk decades before symptoms appear. Yet knowing the mutation does not prevent the cascade. Once the misfolded prion protein begins accumulating, intervention options are limited. Clinical reports are sometimes anonymized to protect families from unwanted attention due to the hereditary nature of the disorder. The most unsettling aspect is conceptual rather than statistical. Sleep is not optional. It is as biologically necessary as oxygen or hydration. Deprive a healthy individual for days, and cognition fractures. In this syndrome, the brain itself eliminates its own ability to disengage. The switch that should dim consciousness remains permanently stuck in the on position. If a single misfolded protein can erase one of the most essential survival functions in the human body, what does that reveal about the fragility of neurological balance? And how many other foundational systems operate on molecular mechanisms that could fail just as silently, without warning, until the body can no longer sustain itself? Top 4. The Locked-In Mind. In 1997, a 43-year-old high school teacher in France suffered a massive stroke affecting the ventral portion of his pons, a structure deep within the brainstem measuring barely 1 inch across. When paramedics arrived, he was conscious but unable to speak. Within hours, voluntary movement disappeared almost entirely. By the time he was transferred to intensive care, he could not move his arms, legs, or facial muscles. To the untrained observer, he appeared indistinguishable from a patient in a deep coma. His body lay motionless, eyes partially open, unresponsive to verbal commands. The initial medical report listed him as uncommunicative and possibly unconscious. But electroencephalography told a different story. Brainwave patterns showed organized, wake-like activity. When clinicians spoke his name, subtle changes in cortical signals appeared. Functional imaging performed later demonstrated preserved activity in regions associated with language comprehension and internal thought. The injury had severed motor pathways descending from the brain to the spinal cord. Yet large portions of cognition remained intact. The mind was awake. The body was not responding. This condition is known as locked-in syndrome. It most commonly results from ischemic stroke, hemorrhage, or traumatic injury to the brainstem, particularly the ventral pons, where corticospinal and corticobulbar tracts pass in dense bundles. These neural highways carry commands from the motor cortex to the limbs and facial muscles. When interrupted, voluntary movement below the eyes can vanish almost completely. However, the reticular activating system, which maintains consciousness, often remains preserved. In many cases, vertical eye movement and blinking survive because the responsible pathways are located elsewhere. Those minimal motions become the only bridge between an intact mind and the outside world. Clinical assessments reveal a chilling paradox. Patients can often understand complex sentences, recall memories, experience emotions, and think with full clarity, yet they cannot speak or gesture. Communication, when possible, relies on coded blinking. One blink for yes, two for no. Letters spelled out slowly while the patient signals when the correct one is reached. Entire books have been written this way, one letter at a time. The internal experience remains private, vivid, and inaccessible unless clinicians recognize the signs. Misdiagnosis is a documented risk. Without careful neurological evaluation, locked-in syndrome may be confused with coma or vegetative state. Advanced neuroimaging studies have shown that some patients initially believed to be unconscious display patterns of intentional brain activity when asked to imagine specific tasks, such as playing tennis or navigating their home. These mental exercises produce distinct activation signatures detectable on functional MRI. The implication is not speculative. Conscious awareness can persist even when outward behavior suggests absence. There is no simple reversal. Rehabilitation focuses on assistive communication technologies and prevention of secondary complications. Some patients regain limited movement over months or years. Many do not. The medical literature treats the condition as rare but well documented. Survival depends on respiratory stability and long-term supportive care. The deeper tension lies in what the syndrome reveals about the architecture of human awareness. Consciousness, speech, and voluntary movement are often assumed to be inseparable expressions of self. Locked-in syndrome fractures that assumption. It demonstrates that thought can continue in isolation from action. A person can remain fully present behind an unmoving exterior. If awareness can exist independently of almost all physical expression, then outward responsiveness is an unreliable measure of inner life. And if modern medicine once mistook conscious patients for unconscious ones, how many other states of mind remain misunderstood simply because they cannot move enough to be noticed? Top 5. The extreme placebo response. In 1955, a patient at a California hospital was admitted with advanced lymphosarcoma. Medical notes described tumors the size of oranges pressing against his neck and chest wall. Conventional treatments had failed. According to case documentation later cited in medical literature, he was given an experimental drug that physicians believed might offer limited benefit. Within days, the masses appeared to shrink dramatically. Fluid accumulation decreased. His breathing improved. He walked out of the hospital. Months later, when reports emerged suggesting the drug was ineffective, the patient relapsed after learning the news. Physicians then administered a saline injection, telling him it was a more powerful version of the treatment. The tumors reportedly regressed again. While individual anecdotes require caution, controlled clinical trials have repeatedly confirmed a measurable placebo effect. In double-blind studies, patients receiving inert substances often demonstrate improvements comparable to those receiving active medication, particularly in pain management, depression, and certain neurological conditions. Brain imaging has shown that belief in treatment can activate endogenous opioid pathways, releasing endorphins that reduce pain perception. Dopamine signaling in reward circuits also increases when patients expect therapeutic benefit. The body responds not only to chemical compounds, but to expectation itself. In some documented trials, even objective biological markers shift. In Parkinson's disease studies, placebo administration has triggered dopamine release measurable through positron emission tomography. In immune research, conditioned responses have altered inflammatory markers when subjects believed they were receiving active agents. These changes are not imaginary. They are quantifiable alterations in neurotransmitters, hormones, and immune activity initiated by cognitive processes. The term placebo is often misunderstood as deception. In modern trials, participants are informed that they may receive an inactive substance. Yet the context of care, the authority of physicians, and the ritual of treatment can still produce measurable physiological shifts, the phenomenon extends further. Open-label placebo studies where patients are explicitly told they are receiving inert pills have still demonstrated symptom reduction in conditions such as irritable bowel syndrome. The mechanism remains under investigation, but the data suggests that belief and expectation can influence autonomic and endocrine systems in ways not fully mapped. The boundaries, however, are clear. Placebo effects do not regrow amputated limbs or eradicate severe infections. They do not replace surgical intervention when structural damage is present. But within certain domains, particularly those involving perception, mood, and immune modulation, the magnitude of response can be significant. This has forced medicine to incorporate placebo controls as a standard requirement for evaluating new therapies. Without comparison to expectation-driven improvement, efficacy claims would be unreliable. The unsettling dimension is conceptual. If belief can trigger measurable neurochemical cascades, then cognition occupies a regulatory role more powerful than once assumed. The brain is not merely interpreting bodily signals. It can initiate them. It can dampen pain, alter motor symptoms, and influence inflammatory processes based on internal narrative. This does not imply that illness is imagined or that positive thinking overrides pathology. Rather, it reveals that perception and physiology are deeply intertwined. The same neural circuits that process hope and trust intersect with pathways governing pain modulation and immune response. If expectation alone can shift measurable biomarkers, then modern medicine may be observing only part of the equation when evaluating treatment outcomes. The molecule matters. The dosage matters. But so does the story the brain tells itself about what is happening. And if belief can reshape certain biological responses under controlled conditions, how much of human physiology operates under cognitive influence that remains unquantified, hidden behind mechanisms still too subtle to isolate? Top 6. The Spontaneous Remission Files. In 1999, oncologists at a major hospital in Tokyo reviewed imaging scans of a 61-year-old man diagnosed months earlier with advanced hepatocellular carcinoma. Initial CT images showed multiple lesions distributed across the right lobe of the liver, some measuring more than 2 inches in diameter. Surgical options were limited. Chemotherapy had not yet begun due to underlying complications. The prognosis was guarded. Yet when follow-up imaging was performed several weeks later, radiologists reported a reduction in tumor size that could not be easily attributed to intervention. By the third scan, several lesions were no longer detectable. The medical record noted the phrase that continues to unsettle clinicians: spontaneous remission. Spontaneous remission is defined as partial or complete disappearance of a malignant tumor in the absence of adequate medical treatment. It is rare, estimated to occur in perhaps 1 in tens of thousands of cancer cases, depending on tumor type. Yet it is documented. Case reports span decades and continents, involving malignancies such as renal cell carcinoma, melanoma, neuroblastoma, and certain lymphomas. These are not anecdotal rumors circulating online. They are recorded in peer-reviewed journals, though often described with caution and limited interpretation. Several hypotheses attempt to explain the phenomenon. One leading theory involves immune system activation. The human immune system continuously patrols for abnormal cells. T lymphocytes can recognize tumor-specific antigens and initiate cytotoxic responses. In some documented cases, spontaneous regression followed acute infection or high fever. It has been proposed that immune activation triggered by infection may have inadvertently enhanced anti-tumor surveillance. Cytokine storms, though dangerous in excess, can amplify immune signaling in ways that alter tumor microenvironments. Another proposed mechanism involves angiogenesis disruption. Tumors rely on blood vessel formation to sustain growth. If vascular supply collapses due to thrombosis or immune-mediated damage, rapid shrinkage can occur. Hormonal shifts have also been considered, particularly in hormonally sensitive cancers. Yet no single mechanism accounts for all cases. Many remissions occur without identifiable infection, fever, or detectable immune surge. Modern oncology acknowledges spontaneous remission, but does not rely on it. It remains unpredictable, unprogrammable, and statistically rare. Because it cannot be induced reliably, it does not form the basis of treatment protocols. In clinical trials, such events are often categorized separately to avoid skewing data on therapeutic efficacy. Researchers investigate underlying mechanisms, but conclusions remain provisional. The tension lies in the implications. Cancer is typically framed as a breakdown of cellular regulation, a failure of apoptosis, unchecked proliferation driven by genetic mutation. Treatment strategies aim to destroy malignant cells directly or enhance immune targeting through engineered approaches such as checkpoint inhibitors. Yet spontaneous remissions suggest that under certain conditions, the body may mount a response powerful enough to reverse advanced disease without external cytotoxic force. This does not imply that cancer will disappear if ignored. The overwhelming majority of untreated malignancies progress, but the documented exceptions reveal a capacity within the organism that is not fully understood. Somewhere within the immune architecture may exist regulatory states that, once activated, can dismantle complex tumor systems. If such states are real but rare, the question becomes whether they are inaccessible by chance or simply poorly mapped by current models. Does the body possess emergency protocols that activate only under specific biological thresholds? And if spontaneous remission represents a glimpse of that hidden potential, what other defense mechanisms remain dormant, beyond the predictable pathways modern medicine has learned to manipulate? Top 7. The Tao's frequency sensitivity. In the early 1990s, residents of a small community near Taos, New Mexico, began filing complaints that did not fit any conventional medical category. A persistent low-frequency hum, described as a distant diesel engine idling or a vibration beneath the earth, was reportedly audible to a small percentage of the population. The sound was most noticeable at night, indoors, when environmental noise was minimal. Those affected described sleep disruption, headaches, nausea, and difficulty concentrating. Others living in the same buildings heard nothing at all. In 1993, a formal investigation was initiated, involving engineers, audiologists, and physicists. Sensitive microphones and spectrum analyzers were deployed to detect infrasound and low-frequency acoustic emissions below 100 Hz. Environmental surveys examined potential industrial sources, ventilation systems, distant traffic patterns, and geological activity. While sporadic low-frequency noise was detected, no single consistent external source matched the persistent reports. The majority of residents remained unaffected. A minority insisted the hum was continuous and unmistakable. Human hearing typically ranges from 20 Hz to 20,000 Hz, with sensitivity decreasing at the lowest frequencies. However, perception thresholds vary between individuals. Subtle differences in cochlear mechanics, neural processing, or auditory cortex sensitivity may influence detection of faint vibrations. Some researchers propose that those reporting the hum possessed heightened sensitivity to low-frequency environmental noise normally filtered out by the brain. Others suggested internal physiological sources, such as spontaneous autoacoustic emissions or vascular turbulence near the inner ear. Audiometric testing of affected individuals produced mixed results. Standard hearing tests often appeared normal. No structural abnormalities were consistently identified. Psychological assessments ruled out overt psychosis in the majority of complainants. Yet the distress was genuine. Sleep studies documented increased nighttime arousal in some participants who claimed to hear the hum. The absence of a shared, detectable source complicated conclusions. Low-frequency sound behaves differently from higher frequencies. It travels long distances, penetrates walls, and can be felt as vibration rather than heard as tone. Infrasound below 20 Hz may influence the vestibular system and produce sensations of unease. Military and industrial research has documented physiological responses to prolonged low-frequency exposure, including anxiety and altered respiration. However, linking these findings directly to the Taoist reports proved difficult without a reproducible acoustic signature. The phenomenon was not isolated to New Mexico. Similar reports emerged in parts of the United Kingdom, Canada, and Australia, each time involving a small subset of residents. Investigations often ended without definitive explanation. In many cases, environmental noise sources were identified for some complainants, but not all. The broader question extends beyond the hum itself. The human sensory system is not a passive receiver. It actively filters, amplifies, and suppresses signals. Two individuals standing in the same room do not experience identical auditory landscapes. Neural gating mechanisms determine which inputs reach conscious awareness. If those filters vary more widely than assumed, perception becomes partially individualized. The Taos reports highlight a boundary between measurable stimulus and subjective detection. If some nervous systems are tuned to frequencies that others ignore, then environmental reality may not be uniform across observers. The discrepancy does not necessarily imply external mystery, but it exposes variability in sensory processing that remains incompletely mapped. If perception depends as much on neural interpretation as on external signal strength, how many subtle environmental cues pass unnoticed by most, yet remain vivid to a sensitive minority? And what does that variability reveal about the limits of our instruments compared to the adaptability of the human brain? Top 8. The hyperthymesia. Memory cases. In 2006, neuroscientists at the University of California documented a case that initially appeared exaggerated. A 40-year-old woman claimed she could recall nearly every day of her life since adolescence with precise detail. When presented with random dates spanning decades, she identified the day of the week within seconds and described specific personal events associated with it. Independent verification confirmed many of her recollections. Weather reports matched. News headlines aligned. Family members corroborated seemingly minor details that would normally fade into obscurity. Her ability was later classified as highly superior autobiographical memory, often abbreviated as HSAM. Unlike trained memory champions who use mnemonic strategies, individuals with hyperthymesia do not report deliberate techniques. Their recall is automatic and persistent. When prompted with a date such as March 17, 1998, they may describe what they ate for dinner, the clothes they wore, and the television program airing that evening. Functional imaging studies have shown differences in brain regions associated with autobiographical memory, including enlargement or altered connectivity in the caudate nucleus and medial temporal structures. The hippocampus, critical for memory consolidation, appears structurally typical in many cases, suggesting the phenomenon is not simply a matter of size but of network organization. Memory in the average brain is selective and reconstructive. It filters, compresses, and edits experiences to preserve cognitive efficiency. Forgetting is not a flaw, it is a function that prevents overload. In hyperthymesia, that filtering mechanism seems reduced. Personal experiences remain accessible with unusual clarity. The recall is not photographic in the sense of visual snapshots of entire pages or scenes, but autobiographical, anchored in lived context. Dates serve as retrieval keys that unlock cascades of detail. However, the condition is not universally perceived as a gift. Many individuals with HSAM describe difficulty disengaging from painful memories. Embarrassing moments, losses, and regrets remain vivid decades later. Emotional processing may be prolonged because the past does not soften with time. Neuropsychological testing suggests that, while autobiographical memory is enhanced, performance in other memory domains, such as rote memorization of arbitrary lists, may remain average. The phenomenon is highly specific rather than globally superior. Scientific investigation continues to examine whether obsessive traits or repetitive mental rehearsal contribute to the condition. Some individuals report a habit of frequently revisiting past events in thought, which may strengthen neural pathways. Yet this does not fully explain the speed and accuracy of recall demonstrated under controlled conditions. The brain appears to maintain an unusually stable index of personal chronology. The existence of hyperthymesia challenges assumptions about cognitive limits. If most people forget the majority of daily experiences, it may be because the brain is designed to discard excess data. But these cases suggest that, under certain configurations, the nervous system can preserve a far more extensive archive. The bottleneck may not lie in storage capacity, but in retrieval and prioritization mechanisms. If the human brain can, in rare instances, retain decades of autobiographical detail without collapse, then the perceived boundaries of memory may reflect regulatory choices rather than structural constraints. What appears as limitation could be an adaptive filter. And if that filter can vary so dramatically between individuals, what other cognitive capacities operate below the threshold of awareness, not absent, but simply restrained by design? Top 9. The Terminal Lucidity Event. In 2010, physicians at a long-term care facility in Germany documented a case that unsettled even experienced neurologists. An 82-year-old woman with advanced Alzheimer's disease had not recognized her daughter in over 5 years. She required assistance with feeding, dressing, and basic hygiene. Neuroimaging conducted earlier showed extensive cortical atrophy, particularly in temporal regions associated with memory formation. Communication had deteriorated to fragmented words and occasional agitation. According to staff notes, she rarely formed coherent sentences. On a winter evening, hours before her death, something changed. Witnesses reported that she became alert, made sustained eye contact, and began speaking in full sentences. She addressed her daughter by name, apologized for past arguments, and described memories from decades earlier with clarity that had been absent for years. The episode lasted approximately 30 minutes. Shortly afterward, her breathing became shallow. She died during the night. This phenomenon, known as terminal lucidity, has been described in medical literature for more than a century. It refers to a sudden temporary return of mental clarity in patients suffering from severe psychiatric or neurodegenerative conditions shortly before death. Reports involve individuals with advanced dementia, schizophrenia, or brain tumors who, after prolonged cognitive decline, display brief periods of organized thought, memory recall, and coherent speech. The biological mechanism remains uncertain. In Alzheimer's disease, neuronal loss and synaptic degeneration are progressive and largely irreversible. Brain tissue does not regenerate within hours. One hypothesis proposes that metabolic shifts near death may temporarily alter neurotransmitter balance, enhancing residual neural circuits. Another suggests that decreased inflammation or transient changes in cerebral blood flow could permit short-lived restoration of function in surviving neurons. None of these explanations fully account for the depth of clarity sometimes described. Clinical documentation varies in detail, partly because such events are unpredictable and often not recorded with advanced monitoring equipment. In hospice settings, emphasis is placed on comfort rather than experimental measurement. As a result, terminal lucidity is acknowledged but not systematically studied on a large scale. It remains categorized as a rare but real clinical observation rather than a defined neurological process. Importantly, the episodes do not reverse disease. They do not halt degeneration. They are temporary windows, often lasting minutes to hours. Afterward, the patient declines rapidly. For families, the event can be emotionally profound, offering a final opportunity for connection. For clinicians, it presents a puzzle. How can a brain that has lost significant structural integrity briefly reassemble coherent cognition? Neuroscience understands that memory and personality are distributed across networks rather than confined to single locations. Even in advanced disease, islands of functional tissue may remain. It is conceivable that under specific biochemical conditions, these islands synchronize momentarily. Yet such coordination appearing precisely before death introduces variables not yet fully mapped. Terminal lucidity does not imply reversal of pathology. It does not prove preservation of consciousness independent of brain tissue, but it challenges assumptions about linear decline. Cognitive deterioration is often viewed as a one-way trajectory. These episodes suggest that neural function near death may not follow a simple downward slope. If fragments of identity can resurface after years of silence, what does that reveal about how memory is stored and suppressed? And if the brain can, even briefly, reorganize itself at the threshold of death, how much of its capacity remains hidden beneath damage we assume to be final? Top 10. The near-death neuroelectric surge. In 2013, a team of researchers monitoring laboratory animals during controlled cardiac arrest observed an unexpected pattern. Within seconds after the heart stopped beating, electroencephalography recordings displayed a sudden burst of high-frequency gamma activity. For a brief window lasting approximately 20 to 30 seconds, neural oscillations increased in synchronization and intensity beyond baseline waking levels. Instead of fading immediately into silence, The brain exhibited a final surge of organized electrical activity. Subsequent investigations in critical care settings have reported similar findings in limited human cases, where continuous EEG monitoring was in place during end-of-life events. In rare documented instances, shortly after cardiac arrest, transient spikes in gamma frequency bands, often associated with conscious processing and integration of sensory information, were recorded. These bursts were short-lived and not present in every case. However, their existence challenged the assumption that brain activity declines smoothly and uniformly once circulation ceases. Under normal conditions, the brain consumes approximately 20% of the body's oxygen supply, despite representing only about 2% of body mass. When blood flow stops, oxygen depletion begins within seconds. Neurons are highly sensitive to hypoxia, and irreversible damage can occur within minutes. Conventional understanding suggests that electrical activity should rapidly diminish as metabolic support collapses. Yet the observed gamma surges indicate that before shutdown completes, neural networks may enter a brief hypersynchronized state. One proposed explanation involves excitotoxicity. As oxygen levels fall, inhibitory controls may weaken, leading to a temporary cascade of uncontrolled firing across cortical circuits. Another theory suggests that the loss of regulatory balance between excitatory and inhibitory neurons produces a final attempt at network integration. Some researchers speculate that this surge could correlate with vivid subjective experiences reported by survivors of near-death events, such as intensified memories or perceived clarity. However, direct correlation remains unproven due to the difficulty of capturing simultaneous neural data and subjective reports. The scientific community treats these findings cautiously. Sample sizes are small. Monitoring conditions vary. Ethical constraints limit experimental replication. Nonetheless, the data are measurable and reproducible in controlled animal models. The brain does not simply switch off like a light bulb when the heart stops. Instead, there appears to be a transitional phase, a narrow window in which electrical coherence briefly intensifies before collapse. This does not imply awareness after biological death. It does not confirm conscious perception during that surge, but it reveals that the boundary between life and neural silence is not instantaneous. There is a dynamic sequence, a final pattern of activity that unfolds at the threshold. From a biological perspective, the finding underscores how tightly consciousness is tied to electrical rhythms. Gamma oscillations are associated with information binding, attention, and integration across cortical regions. Seeing them amplified at the edge of viability suggests that the brain's final act may not be chaotic noise, but structured activity, however brief. If the dying brain generates a last coordinated signal before silence, it challenges the simplistic notion of a clean cutoff between awareness and absence. The transition appears more complex, layered, and temporally nuanced than once assumed. Across these 10 cases, from the absence of pain to the surge of neural activity at death's edge, a pattern emerges. Core biological systems once considered stable reveal unexpected flexibility, fragility, or hidden capacity. Pain can disappear. Sleep can collapse. Awareness can persist without movement. Belief can alter physiology. Tumors can regress without clear intervention. Memory can expand beyond common limits. Perception can vary between individuals. Combustion can localize in ways that defy intuition. Clarity can return before death. And neural networks can flare at the brink of shutdown. If each phenomenon stands alone, it is an anomaly. If viewed together, they form a question. Are these isolated curiosities, or do they indicate that human biology contains adaptive states and transitional mechanisms not yet fully understood? These biological mysteries reveal a pattern that is difficult to ignore. They are not myths, not folklore, not speculative philosophy. They are documented clinical observations that challenge the assumption that modern medicine has mapped the full architecture of the human body. Individually, each case is rare. Collectively, they suggest that human physiology operates on regulatory layers that are not yet fully decoded. Medicine has identified genes, proteins, neurotransmitters, and pathways. Yet these events imply that additional thresholds and switches exist within the system. Some activate under extreme stress, some deactivate without warning. Some appear only at transitional boundaries between health and decline, consciousness and silence. The consequences are not merely academic. If spontaneous remission reflects an immune configuration not yet harnessed, untapped therapeutic potential may exist. If cognitive states influence measurable biomarkers, treatment models may require broader integration of neurobiological context. If neural activity intensifies at life's end, the process of dying may be more complex than a simple shutdown sequence. The tragedy is not that medicine lacks answers. It is that these rare events are often categorized as anomalies and left at the margins of systematic study. Each unexplained case represents not just a curiosity, but a missing variable in a system we assume we understand. The question is no longer whether these phenomena are real. The data confirm they are. The deeper question is whether we are prepared to reconsider how much of human biology remains adaptive, conditional, and still hidden beneath models that may only describe the surface. If these biological anomalies have changed the way you perceive the limits of the human body, please subscribe to the channel and like this video. We are uncovering the medical mysteries that history and science are still trying to map. Help us grow this community of curiosity. Our next deep dive into the unknown will open soon.